Hello, Dr. Jeevanan Jahendran, better
Hi,
known by many as Dr. JJ. Thank you so much for being here to share some
my
of
pleasure.
your pearls of wisdom. Uh, we
Yeah.
are talking about drilling into the nose, and it's not all about surgery. Dr. JJ is going to share with us today how nasal resistance impacts the way air flows through the whole system. This is really important, and you've got some slides to share with us.
Yep. Let's get those slides on. All right. We're good to go. All right. So for the longest time, in fact, one of the reasons I did ENT was because I've had multiple surgeries done in my nose, six to be exact, and I always felt that there was something missing, with all these surgeries in the nose, and it's been a learning journey. And I think that's one of the reasons I did ENT. And only in the last 6 or 7 years that I've finally begun to understand that it's a lot more than just the nose. But the nose is the key in the whole area of breathing and sleep and swallowing, and whichever way you want to look at it. That is why today in my last talk in Melbourne, I said we need to bring together this whole concept of upper aerodigestive health. It's about breathing, it's about chewing, it's about swallowing, it's about speech. Everything goes together. If one function doesn't work well, it's going to have an impact on all the other functions. So as Sharon, you nicely put, let's drill into that nose. Now, the nice thing about understanding the nose is you just have to think of it as a room within a double-story house. And when we talk about this double-story house, this is this double-story bungalow that sits on the rest of your body, but it houses a lot of important things, your cranial nerves, your brain. So it is the key sort of your central nervous system, your CPU that sits in this area and connects everything else. And we now know that the whole skull is made up of individual bones that is moving together. That's why we talk about cranial strains. And there's a whole lot of nerves, the 12 cranial nerves, and also the entire neurological system, and how it all integrates everything together. But the key to the nose is what we see, this portion of the nose is only about 20 to 30% of your nose. The bulk of your nose actually sits within your skull, and that area relates to the palate. And that is why it's important to understand that the palatal space is important for the nose, as well as creating enough space for the tongue. So you need to have a big enough house for every occupant in that house to be sitting very comfortably and doing what it was meant to do correctly. And all these starts now, as we were discussing, it looks like you have to have a healthy mother, to have a healthy pregnancy, to have a good delivery process, and to start the programming by correctly breastfeeding, getting the feeding correct, getting the breathing correct, getting the sleep correct. It's sort of like everything has to go in nice, neat little packages and has to be sort of brought together for it to function as well as possible.
It's a
And if
bit
you
like, is it like lining up the dominoes?
Yes, absolutely. And it's like building a house. You want to create a good foundation for everything to work well so that you have a good house that will last you as long as possible with the least amount of problems. And that's why we need to get it right early. And to really see that, that function of the nose itself is very intricate and complex. And I made this comment in the meeting that the nose is not a breathing organ. See, when you define breathing, it means that there's gas exchange. The only gas exchange that you're going to see in the nose is the nitric oxide component of it. The rest of it is just, it's an air flow through the nose. And there's a lot of processes that need to go on with that correct airflow. And this is why we talk about filter, we talk about humidification, we talk about,
Heater?
heating, moisturizing, sterilizing. So there's a lot of immune function as well that goes on in your nose. So basically what the nose does is it's processing the air to prepare it for the lungs to exchange that air. And this is where, again, now functionally, breathing is now related to the tongue, because your tongue has to be coupled against the palate to create that space so that there's no leak through the mouth. And that is only going to happen if you have the structure is big enough, mouth is closed, you have good lip seal, you have correct tongue position. for your nose to work. So it's almost like a seesaw, you know. You really have to balance things correctly in the mouth, and you have to balance things correctly in the nose so that it's both sort of coupled and working together. That's how the nose is going to work. So I always say that it's a functional entrance, and it works in tandem by coordinating upper airway anatomy and physiology and reflexes. So you have to get it all right from the beginning. And the moment this programming is correct, everything else is going to be working very correctly. So that was the first slide that, I thought was important to sort of lay the basics before we go into the details of how things in the nose will matter.
Oh, you've made so many important points. I often like to think about the nose as the front door for the air, and the front door, which is actually the small part. It
Yeah.
leads into a long, wide hallway that we really can't see. But also the rest of the airway is a bit like that too, because we can't see it. So it's hard to imagine what's going on in there. But
So
there's
it's like this, I always tell this to doctors when we're talking about examining the nose. I said, I can be an explorer. I can use a camera and an endoscope. I can enter this mouth of the cave and then go in and look and see what exactly this cave is looking at, all the nooks and corners and the crevices and stuff like that. But most people, what they do is they just lift the nose up and shine a torch. So imagine standing at an entrance of a cage with a torchlight and you're just looking in and you're trying to make out what's going on in there. And that is impossible. You really have to look at it like a huge cave, and all you're seeing is you're standing at this entrance looking into this dark cave. You're wondering what's going on in there. And that's the reason why I feel that a good endoscopic examination and a CBCT is a must to make people understand what is going on within the nose. So, when we talk about CBCTs, I mean, CBCT is a boon for us because, number one, it's so much less radiation exposure. You can do it repeatedly, even before treatment, after treatment, to see the changes. So I think we don't have any excuses now to say that we cannot assess this properly before we initiate our treatment. And it is for that reason that in my practice, which is predominantly airway patients, that I insist that it is good to get a sort of a pre-treatment CBCT so that we know what is going on. And most of the dentists have CBCTs. All you need to tell them is you want a good field of vision, and I think a 16 by 12 will be really ideal for that.
It also
So
allows you to look at the soft tissues, right, and the turbinates and inflammation and the right up in the apex, what's going on.
middle meatal area, you really want to see what's going on in the middle meatus. And it's because that we are doing CBCTs in children now that you pick up pathologies that we wouldn't have realized otherwise, like concavulosas or infundibular narrowing, very mild deviated septums. See, for me, when I see a deviated septum, which is atraumatic, it gives me a clue that there is some craniofacial respiratory complex compromise, because that it tells us that the septum may be deflecting because of either a transverse dimension narrowing or a AP dimension narrowing. I think
Yeah.
calls for another slide.
Yeah. Sorry, can I just ask a question about how young you would do a scope?
Any age,
Yep.
as long as probably about above 2, I can already consider getting a scope done already. So this is the slide that I wanted to show. So if you realize this, I don't know, I can't seem to get a pointer on this, but you see those 2 arrows on the skull. The transverse dimension narrowing is the side-to-side narrowing. And if you look at this box that I've shown here, so this box actually reflects, the floor of the box actually reflects the palate. So we are taking this out of the picture now. This portion of the nose now is out of the equation. So we are just looking at that whole box. And if you try and imagine, if I were to squish that box in from front to back or side to side, that bone in the middle, which is your nasal septum, is it going to remain straight or is it going to twist and bend to one side? So normally, the anterior, the front portion of this is not clearly assessed on the CBCT, and your endoscope really gives you a good idea. But when you have a CBCT, you can really see the small little nuances on the deflection. And I look at this deflection and I now start looking at how that whole house is behaving. And always remember that this is a growing house. And the earlier you pick it up, the better it is, or the better chance we get to bring all these things together. So we really need to understand that there's a lot going on here that we need to really sort of take into consideration. And if the earlier we get things right, so I like Kevin, it's a Dutch, that he always says that fix before six. And for me, if we can start work as early as even from birth, this is where your lactation consultants come in, your dentists come in, your myofunctional therapists come in. We know the risk patients now, your preterm deliveries, your instrumental deliveries, your vacuum, your forceps. We know you're going to see certain issues, like for cesarean section, you're going to see things like allergies. They are higher at risk. If parents have got a history of atopy, cesarean section, start looking out. If they've got a higher incidence of colic, if they've got a higher incidence of eczema, start thinking that this is a precursor for allergic diseases later down the line. So we've got studies to show you that earlier onset of eczema, the more severe the eczema, the higher the chance of getting asthma and allergic rhinitis. So it's not a question of treating the eczema, but treating the underlying atopy. Look at the risk factors, look at the underlying causes, start getting that immune system to function well by, looking at your diet, your lifestyle, your environment. And it's not a question of avoidance. Sometimes you need to sort of get the body used to it. It can be intolerance. So you start getting the body to tolerate slowly, and then you're in a better position to deal with things as you're getting older and older. So for me, if you do things before 5, less likely that as an ENT surgeon, I would have to intervene and do more things as the child is older. So it's very preventive. And this is where you cannot sort of sell these ideas to your patient, because hindsight is always perfect. We are seeing these problems in the older age groups, and we are fixing these problems by surgery. It's whichever way you want to look at it, whether with medications or surgery, but it becomes all that more difficult. But how do you sell this idea saying that, look, your child is potentially putting yourself at risk for this later down the line by doing something less invasive, less aggressive? We have potentially looking at making sure that this child doesn't get into these problems. How do you sell that?
Well, the indicators are definitely there early. And the research that links these early problems to the later in life problems also links it to chronic disease. Some of these big preventable chronic diseases like diabetes, cardiovascular risk, etc. Perhaps it's a public health campaign to help people understand more. I know they can be highly successful. But I'd say that making those links between early childhood and what may happen later is quite hard for a lot of people unless they're really taking on that self-advocacy in health, like they really want to be proactive with their health.
And one small thing that I'd like to add here is, and this is where we really need to empower our patients, because they have to make that decisions. And also, it's something that I feel that when we work on this area, they really have to have that trust that what we are doing is something for the benefit of them.
Yeah.
You see, I always say that it's hard to do something and not getting something. You see, it's if you don't get it, does it mean that because of what we did that you didn't get it? It's I don't know if you understand what I'm saying.
Keep going. I'm
If you
I'm
do
with you.
this, all right. Now let's say if I do this and you're not supposed to get hypertension and you don't get hypertension, can we make that link? Is it because of what we did?
It's not provable.
It's
And
not
that is
provable.
the big problem with these prevention strategies. So I always like to
Exactly.
talk about it as early intervention to remove those indicators of poor breathing health, whatever they might be, or
Absolutely.
poor sleep and breathing health.
Yeah. Okay, next question.
Would that
Yeah.
work? Anyway, but we do know you've already started talking about palatal vault dimensions and how that plays a really critical role with how well the nose works or not. You've talked about allergy. You've talked about the middle turbinate, the middle meatus is that channel near the middle hill and valley. Not everybody knows what the turbinates are, but they're
Correct.
literally hills and valleys inside the nose.
Correct. And I think the good thing to understand is we really, computational fluid dynamics has really sort of helped us understand how this, the flow mechanics actually work in the nose. And that is something very interesting that I find. And again, I think it's time to share another video.
Great, let's see.
So I saw this video on YouTube and I thought, this is an amazing video. So if you look at it, right, you can see that this is the inferior turbinate. I don't know if, does my pointer show where
I
that
can
is?
I can see that, yes.
And this is the middle turbinate area here. Now, if you look at that bulk of that airflow, that flow is actually going to go, bulk of it actually enters into that middle meatus area. So when we are breathing quietly, see again, when you realize that we are breathing through our nose, when we talk about meetings and we talk about mouth breathing and nasal breathing, for me, nasal breathing is like you're doing this. That means you're forcefully inhaling air through your nose, which is what doesn't happen. You need to understand that it's your lungs that are actually expanding and it's creating the negative pressure, which is gently bringing air in through your nose on only if your lips are sealed and your tongue is sitting against your palate. That is gentle nasal breathing. So it's like passive airflow, which is moving in through your nose. And have a look at this. And that's how it enters into your area, which is the trachea and the vocal folds, and right down into the lungs. So again, look at that bulk of that airflow that is going into that middle meatal area. So it's sort of like going like this and then coming down at the back like that. So we really have to get this idea that passive breathing will come. We learn how to passive breathe. And this is why that it is so important for us to understand that breathing is all about getting your diaphragm to move correctly and getting the airflow correct. And this is how we should be training our patients. And for this, I think more than myofunctional therapy, I think breathing retraining is also very important and we are intervening in all our patients. And I think these two things I just cannot overemphasize how important this is. Even if you end up doing an adenoidectomy or a tonsillectomy, we need to realize that breathing patterns that patients have developed over the years is a habit that they have developed. So if they have developed a wrong breathing habit, no amount of structural correction is going to change that habit. And this is the reason why I feel that when we talk about adenotonsillectomy as doing surgery to sort of take away the obstruction, we need to understand that even if you take away the obstruction, it doesn't mean that the patient will change the habit of breathing. It depends on the age of the patient.
Exactly.
So
Such
this is
an important point. I could not agree more. Could not agree more. And I'm really glad that you started talking about the important role that the diaphragm is where the breath itself is instigated. Can we go on now and just talk about if the diaphragm and the lungs are doing their job, but then there's points of nasal resistance, either at the nasal valves or somewhere else in the nose.
yeah.
Sometimes palatal expansion can address that resistance, but sometimes not.
Yeah.
Can you talk about that a little bit?
So again, if you look at the area of expansion, what we really want to see is that premaxilla, and that's why the intermolar width is very important. I think Kevin has mentioned that I think the minimum is 28 millimeters. But when we talk about palatal width expansion, what you're actually expanding is the nasal floor. And that is basically the beginning of that airflow we see that when that nose actually enters. So that area, when I look at it, if the palate is narrow, now your turbinates are going to be looking enlarged because if you try and imagine a triangle with two bulbs sitting here, if this is that space, this is going to look normal. But if I bring this narrow, that same thing now is going to look like this. So it's becomes a chicken and egg story here. All right. If you throw in allergies, that's going to make things even worse. And for that reason, whenever we expand, especially in children, you're going to see symptom improvement in terms of breathing because you're creating that nasal floor. But for me, expanding is creating that space. It's like patient may be snoring and struggling to breathe, and you have adenoids and tonsils. You take out the adenoids and tonsils, of course, the patient is going to breathe better. There's no doubt about it. But you have to look at what is actually happening before. And this is why we need to know the why, which is very important. Was it a primary orofacial dysfunction that led to this problem? Or was it a primary structural issue? That means both parents are skeletally narrow and the child is also born being skeletally narrow. So the children who are born skeletally narrow, when you expand them, you're going to see better results. But the problem is if it's a primary oromyofascial dysfunction, that means to start with itself, the muscles are weak. They are breathing wrongly because of weak muscles. And because of that, the muscles did not develop the growth of the bone. When you expand that bone, you don't have adequate muscle strength to keep that expansion. So for me, the initial entry of the nose is where palatal expansion is really going to help your breathing because you're now getting that space. But as a prerequisite, if there's underlying allergies, treat the allergies, treat the nose using your saline rinses, initially with intraneedral steroids for at least a short duration. When I say short duration, I mean at least for 6 months to a year. And then watch the diet, watch the lifestyle, take away all those instigating factors. Now, coming to the second part of the nose is where the air is entering into that middle meatus. And this is where the CBCT becomes important for us because this is a problem where it will not be addressed by palatal expansion in children. That area, now, if you look at when adults, when we do MAPE or SAPE, which is mini implant assisted rapid palatal expansion, you're actually expanding the mid palatal segment. That will open up that area in the nose because you're really sort of pushing that sutures open. Now, for in children, we are not doing that. We are actually, it's more the premaxilla that we actually, we are doing that whole transverse expansion. So you also need to realize that in children, they're still growing. So that space is inherently small. So my nasal surgery is very dependent on the myofunctional therapist or the breathing retraining because if it is still struggling, that means if the child is still struggling to do the exercises or the breathing exercises, I mean, there must be some relative narrowing. And this is where I will address the nose. I will buy space by reducing the size of the turbinates. It doesn't have to be a lot. All you're looking for is that additional 2 to 3 millimeters, which is a big difference for that child. And then I look into that middle meatal area. I look at things like the septal swell, whether the middle turbinates are actually bent laterally outwards, narrowing that middle meatal space, or if there's a concha bullosa, or if there's narrowing of the infundibulum. We can be very, very non-aggressive in these areas. We can do a medialization procedure of the middle turbinate. We can just, sort of crimp the middle turbinate. It's like if it's ballooned out like this, we have a forceps that we can just sort of squish it in together without cutting or damaging anything. You don't want to damage any of these things because these are all normal structures with the nose. So we are just doing temporary stuff to buy space to make it easier for the myofunctional therapist or the breathing retraining specialist to bring things together much more easily.
And it's the surgery that will facilitate better nasal function when palatal expansion alone is when you need more than that
When
to
you need more than
facilitate
that.
the nose. Yeah.
Yeah. So
So
it's
what
not
age, what age would you do that?
5 and above.
Yep, for nasal
Anything
surgery.
anybody above needs 5 years, you can do this surgery. I wouldn't recommend it in younger children for one simple reason. It is hard to do the nasal toileting in the clinic after that.
Yeah,
But
as the
anything above 5,
aftercare.
yeah. Below 5, look at things like adenoids, treat the nose adequately. I rarely, in fact, when I say 5 and above, I think it is on very rare occasion that I do surgery that young. Usually the age where we usually get stuck with is around 7 onwards. 5 to 7 is that transitional age where you can still get away doing a lot of stuff.
You mentioned earlier that one of the most important things in terms of clearing the nose is a saline rinse.
Yeah.
And I've been surprised in my clinic how young they are when they can do it themselves and they do want to be independent. Are you seeing
Yeah.
the same thing?
Yeah. 3, 4 years and above, they're very, very independent to do the sinus rooms on their own. They're very good. You will be surprised with kids. You get them to do it. I guess when they do it, they breathe better. They don't struggle as much. a lot of them by 4, 5, they do it on their own.
Absolutely, absolutely. In fact, they prefer to do it on their own. That
Yeah.
certainly has been my experience.
I've seen older siblings teaching younger siblings how to do it as well.
Yep.
Yeah, so it's fun to watch them, it's just saline rinse. And also the other thing that I've realized is, in Malaysia at least, we've got hot, humid weather year round. And for us, pollution, dust, it's the norm for us.
Yeah.
So this is sort of like a healthy hygiene kind of a thing that we do it. So I just recommend them. And once the nose is clear, a lot of them, when they actually get their mouth closed and the nose is working to do what it's meant to do, even saline rinses, they don't have to do it every day. Like I tell them, just do it like 2, 3 days in a week. Once they're good.
I
The nose
remember
just
an ENT from Stanford talking about how the nose is so underrated in
yes,
terms of the important functions that it has in the body. In fact, I think that was in James Nestor's book,
yeah,
The Breath. Yeah. And you are saying this as well, the nose, the nose, the nose.
yeah.
Do you have any more slides to share with us today?
I think that's about it. I don't, or maybe just this one. Let me just show a little few more pictures. I think pictures speak 1,000 words.
They certainly do, and especially your pictures. So,
So, these are the kind of abnormalities that I was talking about. This is a concha bullosa. Somehow or other on this, I can't seem to get my cursor.
are
Right,
you
where
talking about the image on the left-hand
yeah,
side?
the left-hand side of the screen, you can see that expanded concha bullosa there. So,
Do you want to explain to folks what a concha bullosa is? Many might not know that.
uh, so basically, if you look at it, it looks like this ballooned out. You've got an air cell within the middle turbinate, which narrows the infundibular area. So it's like a balloon.
Hmm.
It's supposed to be completely compact. So you want to see something like this. This is the image on the top right on the screen. That would be something normal, whereas the bottom left would look like how a concha would look like.
Ah,
And in some cases, you would see so this on the lower right is a huge concha bullosa.
mm,
Can you see that? So that is something that will definitely need to be addressed surgically. No amount of palatal expansion is going to make that smaller.
yeah,
Yeah.
yeah.
And
What about polyps in children? Do you see polyps?
very,
Yeah.
almost never. But I think that is something that maybe in the European countries is a problem because cystic fibrosis is something very common, or rather more common in those areas. So that's when you would probably see polyps in children. But in my practice, I almost never see polyps in children.
Are
Never.
there any other pathologies in the nose that you do see in children?
This is something that we do see occasionally in older children in untreated allergic rhinitis, where we see what we call as CCAD, central compartment atopic disease. So you get polypoidal changes on the middle turbinate, and this is a problem, and this sometimes need to be surgically addressed. So we need to reduce that polyp and open up that airway. So by breathing correctly, that will not sort of make things worse.
And
So
so it's not always traditional in ENT to do nasal surgery on children, is that right?
not to say not traditional, we've been basically just, when we see big turbinates doesn't seem to get better with medical treatment, doing a turbinate reduction procedure in children is quite common. But
Oh,
this is something that I'm very, very against. We should never, ever cut the turbinates. We used to do a procedure called turbinectomy, and I think that's a big no-no. I think if anybody is still doing turbinectomy today, it's wrong. We should never ever cut the turbinates. The turbinates are very important structures. That is something that we really must understand. But I think it's not uncommon for ENT surgeons to do just a turbinate reduction procedure, which is usually most of us just use a coblation or radio frequency. It's very, very atraumatic. It's low energy, heals very well. You're just shrinking the turbinates down a little bit. And I think that's the best procedure for children. But This is why we need CBCTs, because we miss a lot of middle terminate pathology that is usually left. And we see improvements, and then after that, we see relapse. And I think as a summary for this whole discussion that we are having, I always say, know the why before you figure out how you're going to deal with it. Because no treatment is going to be perfect by itself, albeit whether it's adenotonsillectomy, whether it's nasal surgery, whether it's palatal expansion. We are just doing procedures because we see things as a problem. I've got problem A, I've got solution A. I've got problem B, I've got solution B. And I think that is the biggest mistake that we are doing. If we just take that trouble, make the effort to understand why did this happen? Look at the parents, look at the children. I mean, the child is coming, sitting in front of you. And one of the things that I tell them is, why are you here? What is your main concern? If this is your concern, then I look at the parents and I said, both of you all do not seem to think that you have any problems. But I look at the father and I said, do you snore? And then, yeah, I snore. That's a problem for me because you missed certain things in childhood. And that's the reason why you're snoring and you're potentially putting yourself at risk for sleep apnea. I look at the mom and I said, do you wake up feeling fresh? Do you have postural issues? Do you get neck stiffness? Do you get shoulder tightness? Do you get anxiety? Do you get panic attacks? She'll tick off probably 3 or 4 of those things. And I said, that's breathing dysfunction in women. You're potentially putting yourself at problems after menopause. Now, look at yourself. You have normalized both these things. My idea of treating this kid is so that this kid doesn't end up like you, potentially. So
And that helps them understand.
that helps them understand why we need. So, and then you go back and then you say, you see, this is how both of y'all are structurally at risk. This is the birth process. This is how you fed the child. This is how you've created this habit, which is now causing these problems here. Now you need to go back and say, if I'm going to fix this, you as parents need to be committed to bring this child along a journey so that the child understands that what we are doing is potentially going to improve 3 things. It's going to aesthetically make the child look prettier or better looking. I want better academic performance and I want better sports performance. And I think that's keeping it as simple as possible.
And
And
they're the 3 things that are important to the families that you see?
And I think the child is, you cannot overemphasize how children look at these 3 things. You get a child who's playing basketball or an athlete, and you tell them by improving this, this is the reason why we're doing it so that you can actually improve. It just sort of like, it's an epiphany for them. It's like, ding, this light bulb goes up and it's like, you see? And wouldn't you want to be one of the smarter kids in school? And on top of that, one of the byproducts of our treatment is we'll give you a better smile and we'll give you a better look. Now, who doesn't want that?
There we go. Dr. Jeevanan Jahendran's wisdom in a nutshell.
Nutshell.
I do have one more question, actually.
Sure.
Do you think that every child in every health clinic should be screened for breathing health and sleep health?
Without a doubt. Without a doubt. And I think with the biggest problem we have now is parents are becoming aware of this, but they cannot find healthcare providers who can do this in an integrated manner. That is the biggest, we are still struggling with resources. Because parents see it. They want help. A lot of the times when I see parents, right, they're like, oh my God, I finally found somebody who understands this. They know. Leave it to parents. It is we, the healthcare providers, are the problems. We are not expanding beyond the horizons of what we were trained to do. And it's very unsettling. It's like I get referrals from ENT colleagues because the moment the parents start talking to them about expansion and myofunctional therapy, they feel lost because they were not trained to look for this. And they'll be like, go and see this guy's nose, And I think it shouldn't be that. I think everybody should be well versed in this, and this should be the new norm. It's going to take 5, 10 years, 15 years, but we will get there. I'm very confident we will get there. And most of the people who buy into this are doctors' children. Because when they start seeing the improvement, then they realize that, okay, this is, and there's no end point to our treatment. It's a continuous game of improving and improving and improving. And it's like cardiac health. If you want good heart, you need to do your exercises, you need to, eat healthy, you need to sleep well. Same thing with this. I don't see any difference. You must work on good health.
It's all connected, and that's a new way of thinking, because I think within the health sector, we've been trained to treat chronic disease and disease states,
Yeah.
but there's a lot that we can avoid by lifestyle choices. So if we were to wind up this conversation with one key take home message,
Mhm.
we'll keep it on the nose, okay?
Yeah.
Is that if there's one short phrase that you could tell every health professional, every mum, every parent about sleep, breathing, and the role of the nose, what is it?
To make sure your nose works, make sure the mouth is closed.
There we go. In a nutshell. Thank you so much. I always love listening to you. You work hard. You are leading the pack in terms of changing the way you work with your patients, and I'm sure they appreciate it very, very much. Thank you.
Yeah.